Hello, and welcome to Module 7 of the Global Health Starter Kit, authored by Bree Zheng and Tuka Zokai. This module covers COVID-19's impact on oral health and the field of dentistry, and is designed to be completed in approximately 30 minutes. While there are numerous resources and references available about these topics, for the purpose of this module, we have curated a small sample of high-quality resources to support your learning outcomes. We encourage you to explore the literature further beyond what is contained in this module. This module is related to 3 competencies from the Global Oral Health Competency Matrix. While these competencies cannot be met through a single teaching module, this module is working toward competency-based best practices in global health for dental education. By the end of this module, learners should be able to describe the reciprocal links between oral health and COVID-19 risk and severity, evaluate the impacts of the pandemic on the dental workforce and global oral health, and identify shortcomings within the oral healthcare system and opportunities for growth.
Major disease outbreaks and pandemics are part of our history and future. These diseases have sparked the invention of vaccines and vaccination campaigns rooted in equity. A major development in the United States during COVID-19 was that dental providers were approved to administer vaccines for the first time in our history. Outbreaks like HIV sparked the use of greater infection control in dental offices, and COVID-19 has been another inflection point in infection control measures. While epidemics and pandemics are devastating diseases, they offer opportunities for scientific advancement, greater infection control, and social change. COVID-19 is a disease caused by the virus SARS-CoV-2, which was first discovered in December 2019. The World Health Organization declared the global pandemic on March 11, 2020, resulting in school closures, economic lockdown, and restriction of country borders. On December 16, 2020, Dr. Ryan Thrower became the first dentist to administer a COVID-19 vaccine. Yet, while vaccine access increased, vaccine nationalism and stockpiling among high-income countries left low-income countries with less bargaining power to combat the emergence of more transmissible and dangerous COVID-19 variants. By November 1, 2021, the global death toll had reached 5 million individuals. The oral cavity is important, both in transmission and symptoms of COVID-19. SARS-CoV-2 is transmitted through direct or indirect human-to-human contact via infected secretions such as respiratory and saliva droplets or contaminated surfaces. This is relevant for dental practices, as most dental procedures generate significant amounts of droplets and aerosols, posing potential risks of infection transmission for dental health workers. SARS-CoV-2 enters the body by binding to ACE2 receptors and can manifest with a range of symptoms, including fever, dry cough, fatigue, muscle pain, and diarrhea. In particular, ageusia, the loss of taste and smell, is a key symptom that can predict positive COVID-19 diagnosis more so than self-reported fever. Given that taste organs are widely distributed in the tongue, where 96% of oral ACE2 positive cells reside, loss of taste as an early COVID-19 symptom supports that the oral cavity may be an initial site of infection by SARS-CoV-2. While COVID-19 can affect multiple organs in the body, the main causes of mortality are severe pneumonia and acute respiratory distress syndrome, which is linked with the cytokine storm, an excessive immune reaction that causes extensive tissue damage, particularly in the connective tissue of the lungs. This is where oral health comes into play. One's oral health influences COVID-19 risk and severity. Patients with periodontal disease are more likely to develop hospital-acquired pneumonia and have elevated levels of cytokines linked to more severe disease outcomes. One reason is that the oral cavity is a significant reservoir for viral replication, which predisposes patients to secondary infections. With severe COVID-19 cases, one study found that more than 50% of deaths manifested bacterial superinfections. The other reason is that systemic inflammation is a main characteristic of periodontitis. For patients with periodontal disease, a large amount of cytokines are continuously produced into circulation, which can modify mucosal surfaces, decrease lung function, and make it more susceptible to secondary bacterial infections. In particular, periodontitis produces high level of cytokine IL-6, and one study showed that high IL-6 levels increased the risk by 22 times for pulmonary complications and mechanical ventilation in hospitalized patients. COVID-19 cannot be considered without addressing social determinants of health. For instance, hypertension, obesity, and diabetes are the three major underlying conditions with the most unfavorable outcomes in COVID-19 patients requiring hospitalization. These conditions are also risk factors for dental diseases linked to lifestyle practices deeply rooted in social and economic circumstances that limit the selection of healthier choices and impact oral health status. Common risk factors include stress, poor diet, substance use disorders, behavioral health issues, domestic violence, and poverty. These risk factors are especially high in vulnerable populations like low socioeconomic groups, minority groups, older adults, low literacy individuals, and rural residents. Preventing disease for high-risk groups not only impacts oral health, but also risk for COVID-19. We encourage you to review Module 4 on social determinants for more in-depth information. Oral diseases are influenced by social disparity epidemics that include poor health literacy, segregated health systems, food insecurity, poverty, a treatment versus prevention culture, and inequitable dental care coverage policies. These epidemics do not happen in isolation. For example, segregated health systems in the United States disproportionately burden vulnerable communities and exacerbate health disparities, contributing to the 33% of emergency department visits that are not managed appropriately. Even now, the percentage of emergency department visits due to dental pain continues to rise each year. Syndemics, or synergistic epidemics, are the aggregation of two or more concurrent or sequential disease clusters in a population. Syndemics can be in the context of epidemics and pandemics. They have biological interactions, which exacerbate the prognosis and burden of disease. COVID-19 and dental decay are syndemic and part of larger social disparity epidemics. For instance, COVID-19 has presented a model of three underlying public health crises in the United States that intersect all other epidemics. The COR syndemic is the concurrent interaction of COVID-19, opioids, or substance use disorders, and racism. Individually, the COVID-19 pandemic and opioid epidemic have been responsible for hundreds of thousands of deaths. Systemic racism, including public perception about people who use opioids, inadequate substance abuse prevention and treatment efforts, heightened risk for COVID-19 exposure, and barriers for testing and healthcare has contributed to the ongoing disparities underlying these health crises. Racism impacts oral health by creating inequitable access to oral health services, worsening psychophysiological outcomes of marginalized communities, and undermining provider-patient relationships, all of which were heightened during the pandemic. While other epidemics continue to impact oral health, addressing the COR syndemic can lead to improved oral and therefore total health. At the root of syndemics, COVID-19 has sparked an awareness of infodemics, an overabundance of misinformation and disinformation that has increased hesitancy, stigmatization, and poor observance of public health measures. Infodemics influence the perception of different connected epidemics. Research shows that vaccine hesitancy overlaps and correlates with topical fluoride hesitancy, both of which are linked with structural racism, lack of supply, and barriers to culturally competent care. Furthermore, disinformation has amplified hate speech and violence. Given that immunizations and fluoridation are frontline preventive strategies in pediatric medicine and dentistry, the growing sentiment of vaccine and fluoride refusal is a significant public health concern. Over the course of the pandemic, utilization of dental services decreased while dental infection increased, with higher global levels of caries, periodontal disease, and stress-related symptoms such as bruxism, chipped teeth, cracked teeth, and TMD symptoms. For example, in Beijing, China, Emergency departments saw a 38% decrease in dental pain-related utilization at the start of the COVID-19 pandemic. Yet dental and oral infection increased from 51% to 71.9% during the pandemic. This trend highlights how emergencies, such as pandemics, cause a disruption in care accessibility.
Let's start by considering structural barriers, such as mitigation and suppression policies. A survey of 20 countries revealed that 75.9% of dentists reported practice closure, with lower-income countries closing more than higher-income countries. When reopening, practices often postponed non-emergency routine care, like preventative cleanings and checkups. Dentists were also forced to decrease patient capacity and space out appointments. This, in combination with backlogged dental work from lockdown, made it very difficult to find available providers. Additionally, patients avoided or postponed dental appointments out of fear of being infected with COVID-19. Quarantine also worsened people's oral hygiene routines and increased dietary patterns like snacking and sugar consumption, linked with food insecurity that forced families to buy cheap, unhealthy options. Furthermore, the pandemic worsened people's sleep hygiene and escalated their stress levels. Stress releases cortisol, which reduces salivary flow and raises the risk of gum disease, tooth decay, and mouth infections, which are reciprocally linked with mood conditions like anxiety, depression, and loneliness. Alcohol consumption and domestic violence rates also rose, leading to increased injuries like oral-facial trauma. While oral complications increased, people's ability to afford care decreased due to economic decline, reduced income, job loss, and compromised government funding and service availability. Dental providers also struggled financially due to shutdowns and higher overhead costs, which made them increase dental care costs for patients. Now, let's start thinking about how these barriers are interconnected. How do lockdowns influence oral health hesitancy? How does social isolation impact job performance and income? How do layoffs, staff redeployment, and workflow interruptions lead to shutdown of services or increased dental fees? How does provider fatigue affect quality of care? Imagine these barriers forming a vicious cycle in which easily preventable tooth decay can snowball into periodontitis or abscesses that require more invasive, traumatic, and costly treatments. COVID-19 also impacted how dental care was provided. Globally, dental practices established screening and triaging protocols. Strict social distancing was implemented. Ventilation systems were improved. Infection control measures were increased, involving bioaerosols, pre-treatment antiseptic rinses, and increased PPE like N95 masks, face shields, shoe covers, or even isolation gowns. Aerosol-generating procedures were minimized, but if they were deemed necessary, rubber dam isolation and high-volume evacuators were often used during procedures. Many countries also transitioned to teledentistry, which we will cover in a later slide. Before we get there, take some time to reflect on the usefulness, feasibility, and accessibility of teledentistry. Here, we have taken a case study of Canada versus Nigeria from the article, Changes in Oral Health Policies and Guidelines During the COVID-19 Pandemic. Think about some of the differences, such as universal health care, which affects how providers receive care if exposed to COVID-19. Take note of reopening strategies. While Canada reopened when cases were decreasing, Nigeria reopened when cases were increasing. Because Nigeria is largely driven by the informal economic sector, the lockdown disproportionately impacted the economy and caused social unrest, forcing the country to reopen early. Given these circumstances, think about why routine dental visits were encouraged in Canada and postponed in Nigeria. Furthermore, consider differences in air filtration guidelines. What infrastructure enables one country to better protect dental providers and patients from contracting COVID-19? For the next few minutes, we encourage you to pause your video to compare and contrast to other countries, using a Venn diagram, table, or any method of choice. A comparison of COVID-19 and HIV/AIDS can provide insight on the longitudinal impacts of pandemics. Just as COVID-19 introduced greater infection control, HIV/AIDS introduced universal precautions and personal protective equipment to the common practice of bare-handed dentistry. But pandemics can also give rise to social profiling and discrimination. Just as COVID-19 sparked anti-Asian sentiment and hate crimes, HIV sparked homophobia and violence against gay and bisexual men, who, even now, still face prejudice when accessing oral health care. Today, HIV infects about 36.9 million people worldwide, and those with HIV are 30 to 50% more likely to die from COVID-19. 2/3 of this population live in sub-Saharan Africa, a region that is completely left behind from worldwide deployment of COVID-19 diagnostics, therapeutics, and vaccines. Failing to control COVID in places with high rates of advanced HIV increases global risk for the emergence of SARS-CoV-2 variants. Public health measures need to tackle COVID-19 and HIV as a syndemic, rather than separate pandemics. Given that over 50% of HIV-positive people develop oral symptoms early in the course of the disease, oral healthcare workers sit in a valuable position to facilitate early detection and decrease the stigma associated with HIV/AIDS. Now, let us examine how we can restructure our oral health systems. While COVID-19 has exposed major shortcomings, it also presents many opportunities for growth towards more interprofessional integration, prevention-focused care, and oral health promotion. One shift that COVID-19 sparked globally was increased dental medical engagement. In Singapore, dental workers were deployed to work collaboratively with clinicians, nurses, pharmacists, radiographers, and social workers to screen cases, provide consultations, and conduct swabbing operations. In the UK, dental staff were deployed in maternity, critical care, and emergency units. In the US, dental volunteers assisted with critical emergency needs and were authorized to administer vaccines in 44 states. This dental medical engagement offers an opportunity for the dental team to be integrated within the broader healthcare system, facilitated by cross-referrals, centralized booking systems, multi-directional service training, and future pandemic preparedness. Given COVID-19's impact on mental health, dental providers can also play an important role in detecting distress, depression, anxiety, and eating disorders, while supporting patients' psychosocial needs. Thus, beyond primary care, integration should be expanded to behavioral health in collaboration with social workers, counselors, and other clinicians. Another change that COVID-19 sparked was the increase in non-aerosol generating procedures, such as atraumatic restorative treatment, chemomechanical caries removal, and silver diamine fluoride application, all of which do not require electricity, local anesthesia, or rotary handpieces. These cost-effective techniques conserve tooth structure, minimize trauma, and reduce pain. And they have been found to be especially useful in children, the elderly, special needs populations, and patients with dental fear or anxiety. The use of non-aerosol generating techniques can kickstart a shift towards minimum intervention dentistry, built upon 4 principles. 1. Recognition and early identification of risk factors. 2. Reduction of risk factors through diet and lifestyle. 3. Regeneration by arresting and reversing lesions through topical means. 4. Repair, using conservative caries removal to restore structure and promote healing. Due to its low cost, minimum intervention dentistry can greatly improve access to services and reduce health inequities, and it shifts dentistry's focus to the entire dental team, rather than the dentist as the main provider of care. Prevention-focused care also conserves resources. During COVID-19, plastic consumption and dental waste increased due to heightened PPE and infection control protocols. Historically, the environment has not been prioritized in the face of disaster relief. Given that health and human well-being are intimately linked with the environment, dental professionals should reflect on more sustainable dentistry and risk reduction strategies. This is explored more in detail in Module 6. The shutdown of dental practices and clinics during COVID-19 allows us to reevaluate the power of oral health promotion, which can address oral hygiene, nutrition intake, tobacco and alcohol cessation, fluoridation, and more. Oral health promotion can function on a macro, meso, and micro level. The macro level involves policy development, agenda setting, and mass media communications to reduce common risk factors for non-communicable disease. The meso level involves a community-based approach, reinforcing oral health habits and behavior in community health centers, schools, workplaces, primary care facilities, and pediatric offices. The micro level involves dentists, hygienists, therapists, nurses, assistants, social workers, and all members of the healthcare workforce, providing preventative messaging inside healthcare settings and in other parts of daily life. Teledentistry and digital oral health can simultaneously enable integration, prevention, and health promotion. COVID-19 accelerated a shift towards teledentistry, which allowed continuous dental care during shutdown and minimized the risk of contamination. Teledentistry can facilitate early detection of oral problems, reduce costs and wait times, improve longitudinal care, link service providers, enable contact tracing, disseminate preventative messages, and combat the spread of misinformation while delivering care when travel is difficult. However, barriers to implementation include internet connectivity, availability of data, licensure issues, insurance coverage, patient liability, and data exploitation. To create an effective teledentistry and digital oral health program, it is essential to first conduct a needs assessment. For instance, 1. What existing national oral health programs are in place? What are their objectives, constraints, institutional resources, and available funding? 2. Are there any geographical, religious, language, literacy, and cultural barriers for your population? 3. What is a region's ICT capacity, and what are the levels of mobile communication and available networks? 4. What are the regulations and legal framework on data management, privacy, security, and consent? As part of the 74th World Health Assembly's Be Healthy, Be Mobile initiative, the WHO developed an M-Oral Health program structured into 4 modules. Module 1, the literacy module, aims to improve oral health literacy, awareness, and advocacy on an individual, community, and policy level. Module 2, the training module, aims to train and raise awareness about oral health for general health professionals. Module 3, the early detection module, provides information on remote diagnostic tools to increase access. Module 4, the surveillance module, uses mobile technology to strengthen oral health surveillance systems and collection of epidemiological data, as well as monitoring of quality patient care and service delivery. The mobile phone market penetration globally means that almost anyone can now be reached via SMS text messaging. It's important to ensure that the digital health revolution is safe, sustainable, and leaves no one behind. If universal access to digital health is promoted globally, it can work to accelerate universal health coverage implementation.
Disease will spread so long as our health systems and communities are fragmented. An interconnected system where professionals, industry leaders, community organizations, and social support programs work together can prevent both oral disease and COVID-19 spread. Population health can be explained through the fable of the elephant in the dark by Rumi. In this fable, 8 wise people are in an unlit room to touch an animal they have never seen before, an elephant. As each person examines a different part of the elephant, they come to a different conclusion of what the animal is. One says it is a strong pillar when touching the leg. One, smooth and firm when touching the tusk. Another, like a throne when touching the back. It is not until the torches are lit that they can see the entire complex creature for what it is. COVID-19 provides an opportunity to light these torches and create an interconnected health system to address the needs of populations together.
So ask yourself, how has COVID impacted the way you view dentistry, global health, and oral health advocacy? Where do you see dentistry going from here? And where are you in the picture? What steps will you be taking as a health professional, student, or prospective student to address syndemics? Whether it's increasing partnerships across disciplines, connecting with community organizations, incorporating digital oral health options, or continuously reflecting on our role in the syndemic context, let's take the lessons from COVID-19 and integrate them into our global health advocacy.